Welcome to On Health with Houston Methodist. I'm Zach Moore. I'm a photographer and editor here, and I'm also a longtime podcaster.
I'm Katie McCallum, former researcher turned health writer, mostly writing for our blogs.
And Katie, cancer is a scary thing, and I think we all know that at some point in our lives we're going to have to get tested for it.
Yeah. Yep. There's screenings, and it depends on your gender and your age, but there's quite a few cancers that we screen for. Cervical cancer for younger women, then you start moving into breast cancer, colorectal cancer, lung cancer if you have a history of smoking.
Yeah.
It is very unnerving to think that something could be lurking in your body.
Yeah.
You have no idea about it, and it kind of gets sprung on you, and when maybe it's either too late or when really aggressive treatment is needed. Totally agree. It's very scary. And
recently, in the last few years, there has been a development of blood tests for cancer.
Yeah, it's really interesting. There's these consumerized almost sort of blood tests that, say or claim, however we want to word it, that they can detect, 50 plus cancers from a single blood draw. Mm-hmm. It does require prescription.
Yeah.
But you can go on the website and telemedicine with one of their doctors on the site, and they'll, provide you the prescription. So essentially it's available to anybody who, has the money to pay for it, wants to pay for it. It's out there. It's right in front of us now. It begs the question, should we be doing this?
Yeah. Well, I understand the appeal because you can just send in some blood and get a result back in the mail, yes or no. Getting screened, in its various forms can be intimidating in and of itself.
Yeah. I think, screenings are tightly defined things, right? Mm-hmm. There's certain age criteria that need to be met especially if you're not high risk and stuff like that. And sometimes you kind of maybe just don't want to wait. You're too scared to wait. And you just, especially in this very data centric world we live in now, and we want everything right now. I want to know right now. Yeah, it sounds like I'm interested. It sounds nice to kind of just do a blood draw and be like, okay, yeah, no, we didn't find any signals for cancer, or hey, we found something concerning. You should go get checked out. I'm interested in it too. I think I have a lot of questions.
Yes.
I think, how often would I need to do this? It's a snapshot in time. How often would I need to do it? How effective are these things?
Right.
Are they going to tell me that I might have cancer and then it turns out I don't? And it's even more scary almost than not knowing anything.
Yeah.
So lots of questions over here on my end for sure.
Lots of questions. And who do we talk to who will give us some answers today, Katie?
We talked to Dr. Brittany Barthelemy. She is a primary care physician here at Houston Methodist. So she's actually probably going to be the first person, if you have questions like me, that you go to talk to and just be like, what's the deal with these? Hi, Dr. Barthelemy. So glad to have you today.
Thank you. So happy to be here.
We're talking about cancer detection blood tests.
Yeah.
And, cancer brings out a pretty visceral reaction in people, I think, for obvious reasons. I think we all probably know someone affected by cancer, whether it's ourselves, a loved one, like a spouse, a parent, a child sometimes. It's a disease that can be very sad. And so naturally, when we hear about something like multi-cancer blood test or multi-cancer detection blood test, your ears perk up.
Yeah.
You want to know more. So we're going to talk about that today. I want to start with the question of how do these tests work?
So they're really interesting. So it's a blood draw, right? So you just go to your lab, they just draw a vial of blood, and then they're looking specifically for DNA that is shed by cancer into the bloodstream.
Okay.
And they're looking at DNA changes, whether that's methylation or mutations or even RNA or proteins or what have you. It depends on the type of test. But they're specifically looking for those DNA fragments that are shed by cancer.
Okay.
And they're able essentially to find the signal of origin. So they're trying to find where did this DNA come from. Mm-hmm. And they're able to distinguish that from normal DNA essentially. And so there's 50 or more cancers that they say that they can test for, which is pretty remarkable. And the thing that they're looking at specifically is that a lot of these cancers can shed DNA before you even have signs or clinical symptoms really. And so they have this preclinical window that they're looking at, right? And so you'll be able to test for cancers before you even have signs of cancer.
Yeah, I think that's the piece too that is so enticing. For instance, when I read about them or see them or get an ad for one, honestly, it's yeah, I want to find it before there are symptoms or even, I'm not even eligible for some of the screenings yet. So it's wait, I could find something even earlier, sign me up.
Yeah.
I guess a follow-up question to that and how they work is, when they detect something, do you know can they tell you like what they think it is, or is it just, hey, something's here?
Yeah. So it's more like, hey, something's here. And so it is really kind of a predictive of like, we think this is the signal of origin. And so if they find that and it's positive, then you would have to go through more workup, whether that's more lab work for more cancer markers or imaging per se, hopefully not biopsy or surgery, but really kind of going through more diagnostic workup when they say it is positive to find out, is this truly the source of origin, essentially?
Gotcha. I read they're not FDA approved.
Correct.
So that kind of triggers the other side of things where you're like, well, why not? This sounds so awesome.
Yeah.
So can you talk to me about what that means and sort of how that's different from other screenings that are sort of approved or standard of care?
Yeah. So having an FDA approval is pretty important, right? And so having an FDA approval makes it a lot easier to be covered by insurances. I think that's a really important thing. And so FDA has their own like really rigorous process to kind of test these like products that are like, are they safe? Are they effective? What is the utility for the clinic? You know, is it going to reduce mortality and XYZ kind of things? And so these are fairly new, and there are some new studies. That being said, I believe they are under FDA review. They just haven't been FDA approved yet.
Gotcha.
And so it's just like, hey, we just don't have enough data to say that this is going to help the general public, essentially. Right. And so that being said, most physicians aren't going to bring up non-FDA approved things to their patients.
Yeah. So that's a great segue into my next question. Yeah. Because my next question was going to be about what happens when, you know, you have a patient that comes in and they're like, hey, I want to do this.
Yeah.
Like, what do you say to them? And what's sort of your guidance there?
I think the really important question is asking the patient what they know, right? And so a lot of times, like you mentioned, we see ads on Instagram or, you know, any social media things.
So it gets
and it's
me.
just like, yeah, it's
yeah.
like, I found this really cool. Like, I really want to get this done. And so, I think it's really understanding, okay, what do you know about these tests? And also understand, like, what are you most worried about? Like, which kind of cancers are you concerned about? Like, do you have a family history of certain kind of cancers? And really talking about that type of things that they're looking for. Because, you know, we do have FDA-approved tests and preventative measures, right? We have screenings for breast cancer. We have screening for cervical cancer. We have screening for lung cancer, for colon cancer. But I know it's scary because, you know, even though we have all these screenings, those only account for 40% of our cancers that we find, right? And so we have a lot of silent cancers that people are worried about. And I think, I mean, I'm not sure if you're aware, but people are really scared about liver cancer, pancreatic cancer, ovarian cancer, because those are silent and those are the type we find when they're stage 4. And so patients do get really worried about those kind of things. But I think providing what we know about these tests and their sensitivities and things like that, and providing that information to the patient would be really important and help them make an informed decision.
Yeah, I think one question I would have is like, how often do I need to do this? You know, like right now, I just had my annual appointment last week. I do my blood work. I do that every year, right? Like, so I guess without the FDA approval, as part of the FDA approval, then you get the guidance on like how often and what age, like when would we start this? Or like,
Correct.
I'm 37. Is that too early to do something like this? Or is 25 too, like, I mean, what are you, like, does age matter? I don't know if you have the answers, but I'm just curious.
So I think just backtracking a little bit and looking at one of the major studies that we have on one of the tests, it's called the PATHFINDER study. And it's a kind of like an intro study into these tests. And it was a relatively smaller population of like 6,600 people were enrolled in this. And it was just random, right? So they didn't necessarily have cancers that they knew about. It was just a general population that did it. And one thing that we have to think about is that unfortunately there was a very false positive rate in these patients. And so I think only out of those 6,600 people, like 92 were positive. And of those 92 positive, 57 of them didn't truly have cancer.
Whoa.
Right. And so that's
super
a pretty high. That's a higher percentage, like 62% had a false positive. Right. And so now you have these patients that are undergoing more workup and a little bit of like anxiety with it, right? Like, and unfortunately, these patients that had false positive had a longer time to kind of resolution, right? They figured out they didn't have cancer. It was like something like 5 months essentially of figuring out what the answer was, versus the patients that were like truly positive. It was a very quick turnaround, like 50 days. So it's a very different kind of workup. And so we do have to think about that when we're kind of looking into that. And so unfortunately, with knowing that stuff, there wasn't a clear like, hey, this may have been positive, maybe not. Let's do it in 3 years. Let's do it in 5. Like, there's not a clear picture.
Right.
So really the recommendation is if you do get it done, you need to be getting it done every single year. And that also being said is if you look at some of them, they really say like 50 years and older, because once you turn like 50 and older, your risk of cancer is just typically higher.
Right.
We don't see as many cancers in the younger population. And so really it's 50 and above with a higher risk. And so if you have things like heart disease, diabetes, stuff like that, right?
Okay.
And potentially yearly, but that's not something that we can go out and say like, yes, we know you need to get this done yearly, because again, it is an expensive test, right? So
yeah, we haven't talked about that part yet.
So we can definitely go into that segue. But yeah, so it is like almost, 600 is the cheapest, 800.
Yeah, I think 800 with a coupon is like what I saw. So.
Up to like $1,400. So they're expensive tests to get done yearly.
Yeah, I mean, that's, if you can't even budget for that, you're budgeting for that.
Yeah.
That's kind of wild.
Yeah.
I mean, and I was going to say is if yearly is the answer, then I think it unfortunately probably wipes out a large portion of people. I mean, some people aren't ever, not even going to be able to scrounge up the 800 once, and then to say, do that every year now on top of all your other kind of health premiums and things like that.
Yeah. I think what's really important when you're talking about the costs of these things is like a lot of times when we're doing cancer screenings, it's like the hope is to reduce mortality, right? We want the least amount of people dying from cancer as we possibly can. So if we can get on top of it with their screenings, then fantastic. Unfortunately, there's not enough data to show that overall this is going to reduce their mortality, right? So now we're paying all this money to try to find cancer earlier. But in the long run, is this really going to reduce your mortality risk? And we just don't know that yet. And so I can't in good faith be like, yes, get it done every single year. It's definitely going to help you.
Gotcha.
And so that's kind of where that struggle lies too.
Okay. Gotcha. I do want to touch on another blood test for cancer that is FDA approved called Shield.
Yes.
This one is for colon cancer specifically.
Yes.
So unlike these kind of multi-cancer detection tests, this one's for colon cancer. It's FDA approved. Can you explain how that one's different, first of all? And then I think the big question everybody wants answered is, can it replace their colonoscopy when they turn 45?
Yeah. So Shield is FDA approved, like you mentioned, and it is still a blood test. And it works a very similar way. So it's looking at the methylation of the DNA, the cells that are shed from the tumor that you might have from colon cancer. So very, very similar. It does have a little bit higher sensitivity, specificity. We don't have to go into the kind of math of it all, but that being said, it is not superior to even a FIT test, which is a yearly stool test. It's not superior to Cologuard, which is a stool test every 3 years, and it's definitely not superior to a colonoscopy. And so when you compare them all, the recommendation for doing a Shield will be like, if you cannot convince a patient to do any of the ones that I just mentioned, then that's better than nothing. It's like, let's just figure out if there is something that we need to work up, essentially. And so really the Shield should be used to bring those untested patients into the tested field.
Gotcha.
There is some concern that if we start getting these patients that we're getting colonoscopies and we're getting Cologuard or what have you, and they go to the Shield, then the amount of colon cancer deaths would actually increase. And so it really is meant to be like a screening tool to bring people in, not to change them over to the Shield.
Yeah, that makes a lot of sense. Another question that I had is, I think a lot of us worry too, and you kind of mentioned it, it's these silent cancers. And so correct me if I'm wrong, we kind of don't have screenings for some of these.
Correct.
So the ovarian cancer, endometrial cancer. So what would you say to someone who is truly really scared about that and is just like, I want to spend the $800 every year? I mean, are we still like, is that truly going to help find that stuff sooner, you think?
Yeah. So I think it's really hard. And I think you need to go back and look kind of at the research that we do have on the study. And so like, again, like the PATHFINDER result in the study was like the major one that we have so far. They're actually revamping it with even more people now. It's going to be like 35,000 people in the United States. I think they're also doing it in the UK maybe. And it's something like 100,000 people. So we're going to have a lot more data hopefully in the near future. But even then, when you look at that, the sensitivity of these tests for stage 1 cancer is very, very low, something between like 13 to 17%.
Which is kind of what you want to find.
Right.
Yeah.
But it's like you're not really getting everybody in that field, right? And so you're going to miss a lot of cancers, unfortunately, because they're early stage and they're not getting picked up by the tests. And that provides a false reassurance, unfortunately, right? So you're like, I got this test done, it was negative, but unfortunately with early stage cancers, it's just not very sensitive at picking them up. So it's just like, well, we're not out of the woods just yet, right? We have to continue with what we can know. And even these silent cancers, like ovarian cancer specifically. So like if you have a family history, if you know that you're BRCA1 or BRCA2 positive, that's something that your provider would kind of go with you through and figure out what screenings. But there is some data that says, hey, even if you do have these and we're doing screening with ultrasounds and stuff like that, the mortality hasn't been decreased, unfortunately. And so they really are trying to figure out how do we decrease this mortality from these cancers, but there just hasn't been a proven way just yet, unfortunately.
Yeah. Well, I mean, it makes sense. It's a complicated thing, right?
Yeah.
It's kind of yourself, but it's diseased, the disease cells that are your own. So like that's a tough thing to catch.
Yeah.
I mean, in your perspective, I always kind of go in my brain to sort of the Elizabeth Holmes story anytime you think of blood-based detection. Do we think it's ever going to really be possible to rely on something like, just a single blood draw to get true answers? Is it just technology, time needs to catch up with technology?
I think so. I think, again, just going back to that same study, they looked at, I think one of the things we haven't talked about is this is a blood-based test. And as you can imagine, the cancer that was most detected was a blood-based cancer.
Oh, yeah.
Right? Hematologic cancer. Because that's where you're getting a lot of the DNA from. And so they looked at that and they went and they put it into an algorithm and they were able to, lower that threshold for solid tumors, so that maybe they're going to pick up solid tumors a little bit better, and raise the threshold for blood cancers, essentially. So they already took that small thing that they saw, changed it, and it improved on follow-up testing. So I think, yes, every time they do these tests, like the PDSA cycles, right? And so you plan, you do all this stuff, you make it better, and then you do it again.
Yeah.
And so every time they do these studies, it seems like it is getting better and better. I just don't know what that timeline's going to be.
So maybe a little too soon, perhaps, and especially if you don't have a spare $1,000 lying around, which I think a lot of us probably don't. Okay, I think I wanted to segue into other ways or just ways to prevent cancer, unless you had something else to kind of weigh in on.
No, nothing. Yeah, and I'm huge on preventative medicine, so I'm super excited to talk about.
Okay, cool. Yeah, well, because I think the whole reason we even want to do these multi-cancer detection tests is because we kind of want to make sure we're healthy and we're good. So, I mean, I guess my question is, and it's very broad, so, you can kind of dive into which part is most interesting to you, maybe. What are those, like, quote unquote, free ways? I know nothing technically is free these days. But what are those free ways to help prevent cancer that you would kind of recommend to a patient who walks in?
I love this because I love when patients come in here like, I'm here for my free exam. And that's perfect, right? And I'm here to talk about all the prevention measures. And so the 4, again, that we mentioned briefly before is breast cancer, right? So your insurance is going to cover getting a mammogram. Your insurance is going to cover getting any further workup that you might need if this is like positive. And so now there is also a lot of, women's clinics around the area where it's like, hey, come get your breast exams, get those done. So there's a lot more opportunity for breast cancer screening.
And that starts age 40 now.
Correct. Okay. Yeah. So they have decreased that age. So 40 is getting covered by insurance. It's at a younger age, right? Okay. And so we've started seeing it at a younger age more and more. And so they definitely decreased that age. And so that's been good. Same thing with colon cancer. It used to be 50 and now it's 45. And so we've briefly talked about those too, but colonoscopies are your like bread and butter. Yeah. And if they don't find anything, it's every 10 years. But if they do find something, depending on what they find, it's every 3 to 5 years possibly. Cologuard is also a really good colon cancer screening. The only way you can get it though is if you do not have an immediate family member with a history of colon cancer. So your mom, dad, brother, sister, as long as they've all never had colon cancer and you've never had an abnormal colonoscopy, then you can get a Cologuard. And that's just a kit that gets sent to your house. Yeah. You do a little stool sample, you like swab it and send it back, and they test the same way they test for like these DNAs, right? And so that's another way. And then there's something called a FIT test, which is just like in office, or you can take it home, but it's every year for colonoscopy. Cervical cancer screening. So that starts at age 21 now. And so this is like something interesting too to think about. It's like when I started getting pap smears, they were every single year, but then they saw the data. I was like, well, we're doing a lot of unnecessary biopsies and things like that, and it's causing more harm than good. And so, as we learn more things, we're able to kind of space things out. And so now when you're in your 20s, it's every 3 years. And then when you're 30 and older, it's every 5 years, because now we're doing co-testing with HPV. And so HPV is like a virus that causes cervical cancer. And so that, because those are both negative, right, you're testing if your cervical cell changes and the virus, and they're both negative, that can spread out your screenings a little bit longer. And then lung cancer is a little bit tricky. You do have to have a smoking history. of about 15 pack years. And so a recent smoker or currently smoking. And that is what you're going to get as a low dose CT scan. And so that is also covered by insurance for our smokers.
Okay. So a lot of kind of things we can do that
Yeah.
insurance covers.
Yeah.
You know, I always find the hesitancy about a colonoscopy interesting. Like, I understand that the prep sounds awful, but like,
Yeah.
especially when I turn 45, it's like the first thing I'm going to do. I want to know what it looks like in there
Yeah.
so I can be totally sure.
Yeah.
And then maybe if everything's good, I would switch to, you know, to
Yeah.
the fecal test or something. But like, I want those images and I want someone to be in there looking and being
Yeah.
like, nope, everything looks good.
Yeah.
You're good. Because that's your first chance
Right.
to kind of
And
like.
I think, you know, polyps are more common than not. And a lot of times they do end up becoming benign. But, you know, I would rather know, is there something that they can, especially because when you're doing a colonoscopy and they find a polyp, they can go ahead and snip it and biopsy it then and there. Right.
Right.
And so with Cologuard, if that does come back positive, like the stool testing, you still have to go back and get the colonoscopy.
Yeah.
And insurance will cover the colonoscopy before. And so it used to be like, this was maybe 5-6 years ago. If your Cologuard was positive and you had to get your colonoscopy, then they considered the colonoscopy diagnostic, and it wasn't covered by insurance. That has since changed.
Okay. Yeah.
And so now if your Cologuard is positive, then your colonoscopy is still considered screening and it is covered by your insurance.
Okay.
So there's always a lot of changes for the good, hopefully. Yeah.
Gotcha. Okay. Aside from screenings, any other kind of healthy habits you'd recommend? I literally this morning was scrolling my news feed and saw an article that was like, these two habits account for 30% of all cancers or something. I didn't click on it because I probably can guess what they are.
Yeah.
I would guess like smoking and drinking.
Yeah. Yeah.
To that note, not smoking, limiting alcohol intake.
Yeah.
What else you got for us?
So I think those two are majors, right? There's a lot of data that smoking and alcohol definitely increases your risk of cancer, especially drinking and alcohol, right? I mean, liver, right? So you have liver cirrhosis, and liver cirrhosis can progress to liver cancer.
How can you check for that?
For liver cirrhosis?
Yeah.
So unfortunately, that's one of those things that is kind of later stage. And so
Okay.
one of the biggest things, I think, especially if you drink more than the recommended amount. So for women, it's 2 standard drinks, right? So your 12 ounce, not your tall boy of beer, or 1 glass of wine a day. And for men, it's 3. And so no more than that per day. And so a lot of times if you're having patients that are drinking more than that, when they come in for their annual exam, we're typically getting screening labs. And part of those screening labs are your liver markers. And so anytime there's a liver marker elevation, then we need to figure out what's causing this. And so then those patients will go through an ultrasound of the liver. They might go through more lab testing as well. And that's when we're going to kind of see that bigger picture. Do you have fatty liver changes? Do you have fluid around the liver? And so we'll know more or less, but there's not a screening measure per se that we're trying to do. Like, hey, you're drinking a lot. We need to figure this out. You know?
Yeah. Not condoning drinking beyond what you just recommended.
Yeah.
But are you saying that if someone were to, they could feel sort of comfortable that if they're keeping up with their annual exams, like probably some early changes might be able to get caught?
Yes. Yeah.
Okay.
Yeah. It's hard to tell too, unfortunately, because sometimes you have, heavier drinkers, but obesity can also increase those risks too. And so obesity is a risk factor for cancers as well, unfortunately. And so a lot of times patients that have, a higher obesity and those liver markers are elevated, then those are, and maybe they're not drinkers. Those are likely going to be more fatty liver changes. And fatty liver can proceed to cirrhosis, which again can further go to cancer. And so it is all something we need to be keeping an eye on. And so yes, backtracking.
Okay. Yeah. Sorry. I'm just that's the one I needed answered. Thank you.
Smoking, alcohol, definitely weight is a big factor too. And then, things we eat is really important. And so a lot of processed foods and stuff like that that's the majority of our diet, and we're not getting a lot of fruits and vegetables, then probably not good for your cell and cell changes, right? And so it's just, be mindful of what we're eating. I'm not saying avoid all processed foods, but, if we can have less and less of it, better.
Yeah, those processed foods are so good.
Yeah, no, it's my dad worked for Frito-Lay growing up, and so I ate chips a lot. You know? So it's hard to avoid, and they can become addictive, right? Just like sodas are, just like alcohol, just like smoking, and so it is definitely something we need to keep an eye on.
Gotcha. Okay. How much does kind of being, I've seen lately a lot of the benefits of being outside and outdoors. What do you tell people who are I exercise, but I'm indoors all day? Are you ever hey, get outside, that helps too? Or do we know enough about that?
I think we do know that for sure being outside helps with vitamin D levels, and we are seeing so much low vitamin D. We're just like not getting outside as much as we used to.
Mine is like non-existent levels.
Yeah, mine was like 13 when I was in medical school, so very, very low, and normal is 30 and above. And so definitely being outside is helpful for that.
Okay.
At the same time, part of the skin cancer realm of like being outside too much can definitely be a concern, since we are talking about cancers as well. So wearing your sunscreen is going to be super important. That is, part of the recommendation. Wearing shaded type of clothing, so they have longer sleeves, any hats or things that are going to cover your neck and your ears. So common areas for skin cancer are tip of the ears and feet, because people don't think about putting lotion on them or covering them up, right? And so it is a very common spot.
I've never thought of the tip of my ears.
Yeah.
So tiny.
Yeah.
Like, okay.
Definitely a tiny.
So just do like a tiny like dab on the finger and okay. Yeah. Okay. I'm going to add that in.
This is also a side note. So like the recommended amount of, nobody ever uses this amount, but the amount of sunscreen you should be using is like a shot glass worth.
Whoa.
That's a lot of sunscreen. Like nobody's putting that much on their body.
No.
So really the important thing is going to be reapplying.
Okay.
Make sure you do use the bottle recommendations of reapply every so often,
Face sunscreen every day?
Yes,
okay.
Definitely.
Okay.
I know, I mean, this might be a little bit more superficial, but women's really concerned about wrinkles and stuff like that. But yes, wearing sunscreen can help prevent wrinkles and things like that, right?
Then that's a bonus.
You have a lot of sun damage. Yeah.
We'll take it.
Yeah.
Okay. Any other kind of healthy habits to think about with cancer prevention? I know we covered quite a few.
Yeah, really watch what we're putting into our bodies. So if we can limit our smoking, if we can limit our alcohol, we can limit, the processed foods we eat, it's going to be really important. Exercising is always going to be super important, and really staying up to date on the screenings that we do have available. Yep. I think that's going to be the most important thing until we get more data. Again, I think these tests are really meant to kind of bridge that gap for the screening tests that we don't have. There's no other option for pancreatic cancer or liver cancer, ovarian cancer, right? Other than getting this like imaging done. And so I really see the utility in this in the future. And hopefully as these kind of tests grow and we get more information with these larger studies, that we can really help target these cancers that we're missing, that we don't have screening tests for.
Yeah, I love that. And also coming to see you probably.
Yeah.
I think one thing, I have a lot of friends who don't go to their annual checkups.
Yeah.
I'm just like, why? It's free. You like pay it. You pay for it in your premiums. And then you get like to have this person give you the peace of mind or help you through like some results that need work and improvements. But I think
I do want to make this little caveat is that your annual exam is free. But depending on your insurance, not all insurances cover screening labs. We still order them, but there may be a chance that you may get a bill for the lab work, depending on the type of insurance you have.
Gotcha. That's a very good caveat.
Yeah.
I think I have been lucky and so far haven't had to worry about that.
Again, it is really dependent on the insurance.
Gotcha. Okay.
Yeah.
All right. Well, anything else? This has been great.
Yeah. Thank you.
Anything else that you want to leave us with regarding these tests? I know you kind of mentioned hopeful for the future that these get even better.
Yeah.
Anything else to leave us with?
Nope. I think that's it. Just stay healthy.
Yeah. That's like the mantra of this podcast. So that's perfect way to end. Thank you so much for being here. We appreciate it.
Thank you for having me.
So very informative conversation, Katie. Based off what y'all said, though, I don't think the blood tests are for me yet for cancer. I just need them to be a little more established, a little more accurate, right? Because that false positive rate alone was like, to me, a red flag.
Yeah, I think those initial studies, which, maybe things have gotten better since they were studied and the one she mentioned, but it was like 60%. And then on top of that, the amount of time it would take to sort of rule out cancer from this, false positive, later turns out to be false positive, but you get a positive result. It's ruled out 3+ months later.
You're sitting there waiting, thinking you have cancer for...
that's scary too, right? So I got the sense from her that there's a lot of hope that these things are going to just keep getting better, more accurate, and can be something that people use in the future, but maybe a little too soon. They're also incredibly expensive, not covered by insurance. And there's a lot of questions that still remain on the how often should you do it? I mean, in theory, every year, she said. This is an $800 test.
Right.
So, I think still a little too soon. But we all know how fast technology moves, especially these days. So, we might be looking at something in the nearish future that could be worthwhile.
Yeah, and look, it's an exciting technology, right? I just want it to be a little more established, a little more reliable. Now, the Shield testing appealed to me because it could potentially take the place of a colonoscopy.
I mean, I think... I think that's
Is that wishful thinking?
Yeah, I would say, I think what I heard from her is colonoscopy is still the screening test that is the most efficient, effective, accurate way to know your current status of colon cancer. The other benefit is if there is a polyp there, they can remove it right away, right? I think what I heard from her is that if you refuse colonoscopy, they would rather you than do this blood-based test called Shield, which is FDA approved. So I think she kind of said it as it's a way to bring those people into the fold that just will not do a colonoscopy.
Yeah, I haven't had to have a colonoscopy yet. I've been fortunate enough not to have to take one. My parents have, and I've heard what they do, and it doesn't appeal to me. So if there is an alternative that excites me and interests me, but of course, I'm always going to do the medically recommended one first.
Yeah. I mean, yeah, I get it though. I'm interested in these tests because I'm not eligible for screening for several of these cancers yet. So in my mind, I'm just like, well, wouldn't it be nice to know right now and not have to wait for the screening? But there's a reason those screenings come later in life. These things just aren't common enough yet to say, like, let's screen earlier. So I get why people are interested. But I'm glad we got some of these questions answered so we can all now make sort of an educated decision. It is an expensive test, so make an educated decision for ourselves of whether we would be interested.
Absolutely. And like you said, technology is always evolving, and in the next few years, who knows where this could be. So it's exciting to be on the front lines of this sort of thing.
Yeah.
All right, that's going to do it for us this time on Health with Houston Methodist. Be sure to share, like, and subscribe wherever you get your podcasts. We drop episodes Tuesday mornings. So until next time, stay tuned and stay healthy.